Chronic kidney disease, or CKD, presents a significant challenge in healthcare, affecting millions worldwide. Beyond its direct impact on kidney function, CKD creates a ripple effect throughout the body, altering various physiological processes. This intricate interplay becomes particularly crucial when considering medication management in CKD patients. The kidneys, renowned for their filtering prowess, play a pivotal role in removing waste products, toxins, and drugs from the bloodstream. This essential excretory function directly influences how medications behave within the body, impacting their efficacy and safety. Unlike individuals with healthy kidneys, CKD patients experience alterations in drug absorption, distribution, metabolism, and excretion, collectively known as pharmacokinetics. These alterations necessitate a nuanced understanding of drug behavior in the context of CKD, as even slight deviations can lead to significant clinical consequences. Imagine a delicate balancing act, the body striving to maintain equilibrium while grappling with impaired kidney function. In this scenario, medications intended as therapeutic agents can tip the scales towards adverse effects if their altered behavior is not carefully considered. This underscores the paramount importance of comprehending pharmacokinetics in CKD, enabling healthcare professionals to make informed decisions regarding drug selection, dosage adjustments, and monitoring strategies. By grasping the intricacies of how CKD influences drug handling, we can optimize therapeutic outcomes while minimizing the risk of harm. This understanding forms the cornerstone of safe and effective medication management in CKD patients, empowering healthcare providers to navigate the complexities of this chronic condition and improve patient well-being. Managing medications in patients with chronic kidney disease extends beyond simply adjusting dosages. It demands a comprehensive understanding of how impaired kidney function affects the intricate dance between drugs and the body. This dance, encompassing both pharmacokinetics and pharmacodynamics, dictates how drugs move within the body and exert their effects. Pharmacokinetics, often remembered by the acronym ADME, absorption, distribution, metabolism, excretion, delves into the journey of a drug from administration to elimination. In CKD, each step of this journey encounters roadblocks posed by impaired kidney function. Absorption, the initial step, can be hindered by changes in the digestive system, often associated with CKD. Once absorbed, the drug's distribution throughout the body is influenced by factors like fluid retention and altered protein binding, common in CKD. Metabolism, the process of breaking down the drug, may also be impaired due to reduced liver function, a frequent companion of CKD. Finally, excretion, the crucial step of drug elimination primarily handled by the kidneys, faces significant hurdles. Imagine a medication as a traveller embarking on a journey through the body, its destination, the site of action where it exerts its therapeutic effect. The first leg of this journey, absorption, involves the drug traversing the intricate landscape of the gastrointestinal tract, crossing barriers to enter the bloodstream. However, in chronic kidney disease, this initial step encounters unexpected detours and roadblocks. CKD, far from being confined to the kidneys, casts a wide net of physiological changes, impacting various organ systems, including the digestive tract. These changes create a less than ideal environment for drug absorption, potentially altering the drug's ability to reach its intended destination in adequate concentrations. Understanding these challenges is paramount in ensuring effective medication management for CKD patients. One of the key hurdles lies in the altered environment of the stomach. CKD can disrupt the stomach's delicate pH balance, making it either more acidic or more alkaline than usual. This seemingly subtle shift can have significant repercussions on drug absorption, particularly for medications that rely on a specific pH level for optimal uptake. Imagine a drug designed to dissolve and be absorbed best in an acidic environment encountering a less acidic stomach due to CKD. Its absorption could be delayed or reduced, leading to suboptimal drug levels in the bloodstream and potentially compromising its therapeutic effect. This emphasizes the need to consider gastric pH variations when prescribing and monitoring medications in CKD patients. The stomach, often perceived as a cauldron of churning acids, plays a crucial role in digesting food and surprisingly influencing drug absorption. Its acidic environment, maintained by a delicate balance of hydrochloric acid and other gastric secretions, provides an ideal setting for certain medications to dissolve and be absorbed into the bloodstream. However, in CKD, this carefully orchestrated balance can be disrupted, leading to alterations in gastric pH. Uremia, a condition characterized by the buildup of waste products in the blood due to impaired kidney function, can shift the stomach's pH towards a less acidic state. This shift can have profound implications for drugs that rely on an acidic environment for optimal absorption. Iron supplements, for instance, rely on the acidic milieu of the stomach to convert ferric iron to ferrous iron, the form readily absorbed by the body. A less acidic environment, as seen in CKD, can hinder this conversion, reducing iron absorption and potentially exacerbating anemia, a common complication in CKD. Similarly, certain antifungal medications like ketoconazole depend on an acidic pH for optimal dissolution and absorption. A shift towards a less acidic stomach can compromise their effectiveness, making it challenging to achieve therapeutic drug levels and potentially impacting treatment outcomes. This highlights the importance of considering gastric pH variations when prescribing medications in CKD patients, particularly those requiring specific pH conditions for optimal absorption. Section 3, time and transit. Slowed motility and its impact on drug absorption in CKD. The journey of a drug through the digestive system resembles a carefully timed relay race, with each segment contributing to its overall absorption. While gastric pH sets the stage, the rate at which the drug moves through the stomach and intestines, known as gastric motility, plays an equally crucial role. In CKD, however, this well-coordinated transit system can experience delays, much like a traffic jam on a busy highway. Uremia, the culprit behind many CKD-related complications, can also slow down gastric motility, leading to delayed gastric emptying. a condition where the stomach takes longer than usual to empty its contents into the small intestine. This seemingly minor delay can have significant repercussions on drug absorption, particularly for medications designed for rapid absorption in the upper gastrointestinal tract. A slowed transit time means the drug spends a longer time in the stomach, potentially exposing it to a harsher environment and increasing the likelihood of degradation before it reaches its absorption site. Consider a medication intended for rapid absorption in the small intestine encountering delayed gastric emptying due to CKD. Instead of swiftly moving to its absorption site, it lingers in the stomach, facing a more acidic environment and potential degradation. This delayed transit can lead to reduced drug levels in the bloodstream, potentially compromising its therapeutic effect and necessitating dose adjustments or alternative formulations. This underscores the importance of considering gastric motility when prescribing medications in CKD, especially those requiring rapid absorption for optimal efficacy. Section 1. Navigating the current drug distribution challenges in CKD. Once a drug successfully navigates the hurdles of absorption, it embarks on the next leg of its journey, distribution. Imagine the bloodstream as a network of rivers and streams carrying the drug throughout the body to reach its target sites. However, in the landscape of chronic kidney disease or CKD, these waterways are often turbulent, altering the drug's distribution pattern and potentially leading it astray. CKD, with its far-reaching physiological effects, disrupts the delicate balance of fluids and proteins in the body, creating an environment where drug distribution faces unexpected challenges. These challenges can impact the drug's ability to reach its intended destinations in adequate concentrations, potentially compromising its therapeutic effect and increasing the risk of adverse events. One of the key factors influencing drug distribution is protein binding. Many drugs, once in the bloodstream, bind to proteins, particularly albumin, the most abundant protein in plasma. This binding acts like a temporary chaperone, with the bound drug remaining inactive while the unbound or free drug exerts its therapeutic effect. However, CKD often leads to hypoalbuminemia, a condition characterized by low levels of albumin in the blood. This protein deficiency creates a scarcity of binding sites, leaving a greater proportion of the drug unbound and free to exert its effects. While this might seem beneficial, it can actually increase the risk of toxicity, as a higher concentration of free drug is available to interact with target tissues. Section 2. The protein conundrum. Hypoalbuminemia and drug binding in CKD. Imagine a crowded dance floor with drug molecules seeking partners in the form of protein molecules, particularly albumin. This protein binding, a common occurrence in drug distribution, acts as a delicate balancing act, determining how much of the drug is free to exert its effects and how much remains bound and inactive. However, in the setting of CKD, this delicate dance is disrupted. CKD often leads to hypoalbuminemia, a condition characterized by a shortage of albumin partners on the dance floor. This shortage has significant implications for drugs that rely heavily on protein binding, as it alters the ratio of bound to unbound drug in the bloodstream. Consider a drug that typically exhibits high protein binding, meaning a large proportion of it remains bound to albumin, with only a small fraction available as free drug. In CKD, with fewer albumin molecules available, a greater proportion of the drug remains unbound, leading to higher levels of free drug in circulation. This increase in free drug concentration, while seemingly beneficial, can tip the scales towards toxicity. A higher concentration of free drug means a greater amount is available to interact with target tissues, potentially leading to exaggerated drug effects and an increased risk of adverse events. This underscores the importance of considering protein binding, particularly in the context of hypoalbuminemia, when prescribing and monitoring medications in CKD patients. Section 3, shifting territories. Fluid shifts and drug distribution in CKD. The human body, a marvel of intricate systems, relies on a delicate balance of fluids within its various compartments. These fluid compartments, separated by semi-permeable membranes, ensure the proper distribution of nutrients, electrolytes, and importantly medications throughout the body. However, CKD, with its propensity for fluid dysregulation, can disrupt this delicate equilibrium, leading to fluid shifts that impact drug distribution. These shifts can alter the concentration of drugs in different tissues, potentially affecting their efficacy and safety. One of the hallmarks of CKD is fluid retention, often manifesting as edema or swelling in the extremities. This fluid overload primarily affects the extracellular fluid compartment, the space outside of cells. Drugs that primarily distribute in the extracellular fluid, such as aminoglycosides, may become diluted in this expanded compartment, leading to lower than expected drug concentrations. Conversely, drugs that readily cross cell membranes and distribute into intracellular fluid, such as certain antibiotics and antivirals, may find their distribution altered by changes in cell membrane permeability associated with CKD. This altered permeability can either enhance or hinder drug entry into cells, impacting their effectiveness. Section 1, the metabolic maze, CKD's impact on drug breakdown. As a drug continues its journey through the body, it encounters another crucial checkpoint, metabolism. This intricate process, often likened to a biological transformation, involves breaking down the drug into smaller, more readily excretable molecules. The liver, the body's primary metabolic powerhouse, plays a central role in this transformation, utilizing a complex array of enzymes to carry out its task. However, in the setting of CKD, this well-coordinated metabolic machinery faces significant challenges. CKD, with its far-reaching physiological effects, can impair liver function, disrupting drug metabolism and altering the delicate balance between drug activation, inactivation, and elimination. Imagine the liver as a bustling factory with various enzymes acting as specialized workers, each responsible for a specific metabolic task. In CKD, some of these workers may be less efficient or even absent, slowing down the production line and leading to a buildup of unprocessed products. This metabolic slowdown can have significant implications for drug action, particularly for drugs that rely heavily on hepatic metabolism for elimination. A slower metabolic rate means the drug remains in the body for a longer duration, potentially leading to increased drug exposure and an elevated risk of adverse effects. This emphasizes the need to consider CKD's impact on drug metabolism when making therapeutic decisions. Section 2, the liver's load, impaired hepatic metabolism in CKD. The liver, a resilient organ with remarkable regenerative capacity, faces a constant barrage of metabolic challenges. It filters toxins, synthesizes essential proteins, and plays a critical role in drug metabolism, ensuring that medications are processed and eliminated efficiently. However, CKD can significantly burden this already hard-working organ. Impaired kidney function leads to the accumulation of uremic toxins in the bloodstream, many of which the liver must filter and detoxify. This added workload can strain the liver's metabolic capacity, affecting its ability to process drugs effectively. Imagine the liver as a filtration system, working tirelessly to remove impurities from the bloodstream. CKD, with its influx of uremic toxins, is like adding a surge of contaminants to the system, overwhelming its capacity and potentially damaging the filtration mechanism itself. This impairment in hepatic metabolism can have significant implications for drug therapy in CKD. Drugs that rely heavily on the liver for breakdown, such as certain painkillers, anti-anxiety medications, and cholesterol-lowering drugs may require dosage adjustments or alternative treatment options to avoid the risk of drug accumulation and toxicity. Section 3, beyond the liver, other players in CKD's metabolic drama. While the liver undoubtedly takes centre stage in drug metabolism, it's not the only player in this complex biological drama. Other organs and systems, often overlooked, also contribute to the intricate process of drug breakdown and elimination. In the setting of CKD, these supporting actors can also experience disruptions, further complicating the metabolic landscape and influencing drug behaviour within the body. Understanding these often subtle alterations is crucial for optimizing drug therapy and minimizing the risk of adverse events in CKD patients. The gut microbiome, a complex ecosystem of trillions of bacteria residing in the intestines, plays a surprisingly significant role in drug metabolism. These microbial inhabitants possess their own set of enzymes capable of breaking down certain drugs, influencing their absorption, bioavailability, and even their therapeutic effects. CKD, with its associated dietary restrictions, electrolyte imbalances, and frequent use of antibiotics, can disrupt the delicate balance of the gut microbiome. These disruptions can alter the abundance and diversity of gut bacteria, potentially affecting their ability to metabolize drugs and leading to unpredictable drug responses. Section 1. The exit strategy. Drug excretion challenges in CKD. Imagine a bustling city, its streets teeming with vehicles transporting goods and people. Just as a well-coordinated traffic flow is essential for a city's smooth functioning, efficient drug excretion is crucial for maintaining the body's internal balance. The kidneys, acting as the body's waste disposal system, play a central role in this process, filtering out metabolic byproducts, toxins and drugs from the bloodstream and excreting them in urine. However, in the setting of CKD, this well-oiled excretion machinery faces significant challenges. CKD, with its progressive damage to the kidney's filtering units, the nephrons, disrupts the body's ability to eliminate drugs effectively. This disruption can lead to drug accumulation, increasing the risk of adverse effects and complicating medication management. Consider the kidneys as a sophisticated filtration system, separating waste products and drugs from the bloodstream and directing them towards excretion. CKD, with its impact on nephron function, is like clogging the filters in this system, slowing down the flow and allowing waste products and drugs to build up. This impaired excretion can have profound implications for drug therapy in CKD. Drugs that rely heavily on renal excretion, such as certain antibiotics, painkillers, and heart medications, may require dosage adjustments or alternative treatment options to avoid the risk of drug accumulation and toxicity. Section 2, a traffic jam in the nephrons, reduced renal clearance in CKD. The nephrons, microscopic filtering units within the kidneys, work tirelessly to maintain the body's internal balance. These tiny but mighty structures act like biological sieves, separating waste products and drugs from the bloodstream and funneling them towards excretion. Their efficiency in clearing substances from the blood is measured by renal clearance, a crucial parameter in understanding drug behavior. However, in CKD, these intricate filtration systems face a growing traffic jam. As CKD progresses, nephrons are progressively damaged, reducing their filtering capacity and slowing down the clearance of waste products and drugs from the bloodstream. This reduced renal clearance, a hallmark of CKD, has significant implications for drug dosing and monitoring. Imagine each nephron as a busy highway with cars representing waste products and drugs flowing through. In CKD, these highways become increasingly congested due to lane closures and roadblocks, slowing down traffic flow and increasing the risk of collisions. This reduced clearance means that drugs stay in the body for a longer duration, increasing the risk of side effects and toxicity. Medications that are typically eliminated by the kidneys, such as certain antibiotics, blood pressure medications, and pain relievers, require careful dosage adjustments in CKD patients to avoid these risks. Section 3, beyond the kidneys, alternative routes of excretion in CKD. While the kidneys undoubtedly play the leading role in drug excretion, the body, in its remarkable adaptability, possesses alternative routes for eliminating medications. These alternative pathways, though often less efficient than renal excretion, become increasingly important in the setting of chronic kidney disease, providing a backup system for removing drugs and mitigating the risk of accumulation. Understanding these alternative routes is crucial for optimizing drug therapy in CKD patients, allowing healthcare providers to consider factors that might influence drug clearance and adjust treatment plans accordingly. This knowledge becomes particularly relevant when prescribing medications that are primarily metabolized by the liver or eliminated through other non-renal pathways. The liver, the body's metabolic powerhouse, plays a significant role in drug metabolism, transforming medications into more readily excretable forms. In CKD, as renal function declines, the liver often takes on an even greater role in drug clearance, stepping in to compensate for the kidney's reduced capacity. In addition to hepatic metabolism, other routes of excretion, though generally considered minor players, can contribute to drug elimination in CKD. These include excretion through bile, feces, sweat, saliva, and even breast milk. Imagine a landscape transformed, its contours shifted, its sensitivities heightened. This altered terrain aptly reflects the physiological environment of chronic kidney disease, where drug responses can differ significantly from those observed in individuals with healthy kidneys. This altered responsiveness stems from a complex interplay of factors, including impaired drug clearance, electrolyte imbalances, and modifications in drug receptor sensitivity. Understanding these intricate relationships is paramount in CKD medication management, as even slight deviations from expected drug responses can have significant clinical consequences. This heightened awareness enables healthcare providers to anticipate potential challenges, adjust treatment strategies, and minimize the risk of adverse events. One of the most striking features of this altered terrain is the increased sensitivity to certain drug classes observed in CKD patients. This heightened sensitivity stems from a combination of factors, including impaired drug clearance, leading to higher drug levels in the bloodstream, and potential alterations in drug receptor sensitivity, making target tissues more responsive to drug effects. Opioids commonly prescribed for pain management are a prime example of drugs that warrants careful consideration in CKD. These potent analgesics, while effective in relieving pain, can cause significant respiratory depression, particularly in individuals with impaired kidney function. The kidneys play a crucial role in eliminating opioid metabolites, and their reduced function in CKD can lead to a build-up of these metabolites potentiating respiratory depressant effects. Imagine a delicate ecosystem, its equilibrium maintained by a careful balance of elements. This intricate interplay reflects the body's electrolyte balance, a tightly regulated system where even slight deviations can have profound physiological consequences. In the setting of CKD, this delicate balance is often disrupted, leading to electrolyte imbalances that can significantly influence drug responses, particularly for medications that affect the heart, nerves, and muscles. Understanding these electrolyte shifts and their potential interactions with medications is crucial for safe and effective drug therapy in CKD patients. This knowledge empowers healthcare providers to anticipate potential complications, monitor electrolyte levels closely, and make necessary adjustments to treatment regimens to maintain electrolyte balance and optimize drug responses. Potassium, an essential mineral involved in nerve impulse transmission, muscle contraction, and heart rhythm regulation, often becomes elevated in CKD due to the kidney's reduced ability to excrete it. This condition, known as hyperkalemia, can have life-threatening consequences, particularly in combination with medications that can further increase potassium levels. Certain blood pressure medications such as ACE inhibitors and angiotensin receptor blockers can elevate potassium levels by interfering with the renin-angiotensin-aldosterone system, a hormonal pathway that regulates blood pressure and electrolyte balance. While generally safe and effective in individuals with healthy kidneys, these medications require careful monitoring and potential dosage adjustments in CKD patients to prevent hyperkalemia. Imagine a lock and key, their precise fit essential for unlocking a door. This intricate interaction mirrors the relationship between drugs and their target receptors, specialized proteins located on cell surfaces or within cells that mediate drug effects. Drugs acting as keys bind to these receptors, initiating a cascade of events that ultimately lead to their therapeutic actions. However, in the setting of CKD, this delicate interplay between drugs and their receptors can be altered, influencing drug efficacy and safety. This altered receptor responsiveness stems from a complex interplay of factors, including changes in receptor density, sensitivity, and the presence of uremic toxins that can interfere with drug receptor binding. Uremic toxins, waste products that accumulate in the bloodstream due to impaired kidney function, can bind to drug receptors competing with medications for these binding sites. This competition can reduce drug efficacy as fewer drug molecules are able to bind to their target receptors and exert their therapeutic effects. In addition to uremic toxin interference, CKD can also alter receptor sensitivity, making target tissues either more or less responsive to drug effects. This altered sensitivity can stem from changes in receptor density, the number of receptors present on cell surfaces, or modifications in downstream signaling pathways that mediate drug responses. Navigating the complexities of medication management in patients with chronic kidney disease demands a profound understanding of how this condition reshapes the landscape of drug behaviour within the body. As we've explored, CKD's impact extends far beyond the kidneys, influencing drug absorption, distribution, metabolism, and excretion, collectively known as pharmacokinetics. This intricate interplay between CKD and pharmacokinetics necessitates a shift from a one-size-fits-all approach to a personalised medication strategy tailored to each patient's unique needs and renal function. Recognising the potential for altered drug responses in CKD is paramount. Increased drug sensitivity, often observed in this patient population, highlights the need for cautious drug selection, lower starting doses, and vigilant monitoring for both therapeutic effects and potential adverse events. Electrolyte imbalances, a frequent companion of CKD, further complicate the picture, emphasising the importance of regular electrolyte monitoring and prompt management of any imbalances to prevent drug-induced complications. Dosage adjustments guided by renal function assessments and therapeutic drug monitoring are the cornerstones of safe and effective medication management in CKD. Collaborating with pharmacists, experts in drug therapy and dosage optimization can prove invaluable in developing individualized medication regimens that minimize risks while maximizing therapeutic benefits. Ultimately, successful medication management in CKD hinges on a multidisciplinary approach with healthcare providers, pharmacists, and patients working together to navigate the complexities of drug therapy in the setting of impaired kidney function. By embracing this collaborative spirit and prioritising patient education and empowerment, we can optimise therapeutic outcomes, enhance medication safety, and improve the lives of individuals living with CKD.